Good afternoon, good evening, or good morning, depending on when and from where you're joining us. I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to CDC Public Health Grand Rounds for April 2018, working together to eliminate the threat of hepatitis B and C. We have an exciting session, so let's get started. But first, a few housekeeping slides. Public Health Grand Rounds has continuing education available for physicians, nurses, pharmacists, veterinarians, and health educators. Please see the cdc.gov/getce website for additional information. Grand Rounds is available on the web and social media sites. Please send your questions for this session to grandrounds@cdc.gov, and we will try to include them in the question and answer session at the end. Want to know more about hepatitis B and C? We have a featured video segment on YouTube and on a website called Beyond the Data. This month's segment features my interview with Dr. Cowie. We have also partnered with the CDC Public Health Library to feature scientific articles about eliminating hepatitis B and C. The full listing is available at cdc.gov/scienceclips. Here is a preview of our upcoming Public Health Grand Round topic. Please join us live or on the web at your convenience. In addition to our outstanding speakers, Ms. Katie Burke, Drs. Ward, Page, and Cowie, I'd like to take a moment to acknowledge the important contributions of the individuals listed here. Thank you. And now for a few words from CDC's new director, Dr. Redfield.
Thank you very much, and they emphasized that word few. I'm delighted, actually, for my first Grand Rounds to be a subject that's really close to my heart. I began my career in hepatitis, non-A, non-B hepatitis, and hepatitis B. In the United States today, there's more than 1 million people living with chronic hepatitis B infection and more than 3 million living with chronic hepatitis C infection. Today in the U.S. alone, there's about 75,000 new infections, of which about a little over 30,000 are from hepatitis C and close to 20,000, 19,200 from hepatitis B. Science led to the discovery of hepatitis B back in 1965, and then this discovery led to the development of an efficacious preventive hepatitis B vaccine in the early 80s and more recently into effective antiretroviral therapy. Once again, science also led to the discovery of the hepatitis C in 1989 after literally decades of searching for the cause of non-A, non-B hepatitis. And then this led to successful development of what many of us would have believed really impossible before, now curative antiretroviral therapy for hepatitis C, which has an efficacy rate of over 95%. Yet despite these important advancements, which actually include what we would call a 20th century cure, that is the treatment for hepatitis C, too many Americans still endure the medical complications and death from these now treatable and preventable viral infections such as hepatitis B, or even more so now curable viral diseases such as hepatitis C. So I suggest that now is the time to commit ourselves to collectively respond to what the recent National Academy of Medicine put out was a national strategy for the elimination of hepatitis B and C. To do this, we will need to aggressively implement the scientific discoveries that have occurred in partnership with the state, local, territorial, and tribal public health community, as well as the medical community, and most importantly, also the people at risk for hepatitis B and hepatitis C, and those that are currently living with chronic hepatitis B and hepatitis C infection. We must never underestimate, I've said this before, we must never underestimate the possible. Hepatitis B and C will be eliminated and relinquished into the history books of medicine, and I would state that now is the time to begin that task. Thank you very much.
Thank you, Dr. Redfield. And now for our first speaker, Dr. John Ward.
We could almost stop right there. That was a great intro. Appreciate the opportunity to have to begin the public health grand rounds in this discussion of our way forward to eliminate hepatitis B and hepatitis C. As a brief background, hepatitis B virus and hepatitis C virus are blood-borne, and so as a result, parenteral exposures to blood carry the highest risk, whether that be in healthcare settings or among persons who inject drugs. Hepatitis B virus is also readily transmissible by sexual contact, HCV less so. The risk for morbidity and mortality is a consequence of chronic infection. Persons living with hepatitis B or hepatitis C have about 20 to 25% risk of premature mortality from liver cirrhosis, hepatocellular carcinoma, and extrahepatic manifestations. The prevention strategies we'll be talking about today are hepatitis B vaccine, strategies to prevent exposures to contaminated blood, particularly among persons who inject drugs for the purposes of the United States in this presentation, and then hepatitis B and hepatitis C testing and linkage to care, because therapy can dramatically lower those mortality risks. Hepatitis B and hepatitis C are major global health problems. In 2015, there were about 1.3 million deaths from hepatitis B or hepatitis C, with the numbers you see there. About 50% of all primary liver cancer around the world are caused by these two infections. That's about the third leading cause of cancer mortality. Globally, there are about 328 million people living with that chronic infection and at risk for that mortality. About 80% of that is a consequence of HBV infection. The two maps you see here show you where the prevalence is highest. For hepatitis B, it tends to be in the countries of Asia, including China, and sub-Saharan Africa. For hepatitis C, it tends to be in Egypt, certain countries of Asia, such as Pakistan and Mongolia, and most countries of Eastern Europe. Viral hepatitis is the seventh leading cause of mortality globally. The number of deaths that I've showed you are really right in the same range as the deaths from HIV, TB, and malaria, infections for which there are major global efforts to control and even eliminate. And as you can see there, the trend for viral hepatitis is rising in contrast to those other diseases that I mentioned. Now, because of the availability of those prevention interventions and concern about this rising burden, led the United Nations to call on the global community to combat hepatitis as part of their Sustainable Development Goals that were recently released. In 2016, the World Health Organization, with the endorsement of the World Health Assembly, released new goals for the elimination of hepatitis B and hepatitis C as global health threats, which they defined as a 65% reduction in mortality and a 90% reduction in incidence. They also encourage nations to develop their own goals tailored to their local situation. And in that vein, the U.S. National Academy of Sciences looked at the feasibility of elimination goals for our country, and in 2017 proposed the same goals for hepatitis C as the ones that were put forth by WHO, and they recommend slightly different goals for hepatitis B: the complete elimination of transmission among children less than 5, and a 50% reduction in mortality. Now let's look and see what are some of the opportunities and challenges as we put these interventions to work. Hepatitis B vaccine is the cornerstone of hepatitis B elimination. For example, the countries of the Western Pacific region of WHO, which has that highest prevalence, typically over 8%, they pledged themselves to increase infant immunization beginning at birth in all of those countries to decrease that prevalence to less than 1%. As you can see, as the vaccine coverage rose, the number of infections fell, and in 2017, as a region, they successfully achieved the goal that they set out for themselves. Vaccine is also the cornerstone for hepatitis B elimination in our country. We need to continue to improve birth dose coverage. In addition, we screen pregnant women for evidence of active hepatitis B infection, and if they are positive, we have additional strategies to protect the infant with immune globulin, and most recently to recommend antiviral prophylaxis for women that have very high viral loads. And taking that together, we should be able to reach that goal that the NAS has set for ourselves. Now, to reduce the death rate by 50%, we're going to have to be mindful of the epidemiology in our country. You can see the range of the number of people living with hepatitis B. About half of those people are of Asian or Pacific Island ancestry, reflecting migration patterns into our country and the decreasing incidence as a consequence of our vaccination programs. Hepatitis B testing and linkage to care can decrease mortality risk by 50 to 60%, but a large proportion of people are unaware of their status and not receiving those treatments that can be helpful for them. What we have found in our demonstration projects in collaboration with our local partners is that if you develop culturally appropriate, linguistically appropriate programs, you can do a very good job of engaging people into the testing process and getting them reliably linked to care and beginning to receive the treatments that they need. Now, the good news, as Bob just mentioned, is that HCV can now be cured. We have about 3.5 million people living with hepatitis C based on the published health surveys. The great majority of those persons were born in 1945 through 1965, the so-called baby boomers, and that's where most of the mortality happens. And as a consequence, we have recommended a one-time test for HCV for that birth cohort. Treatment is really dramatically improved. You have, with 1 to several pills a day, taken for 8 to 12 weeks, you can get over a 95% cure of people who are living with this infection, with a dramatic declines in their mortality risk, as shown here. But we also have a problem with a large proportion of people still unaware of their infection, because this is a very silent infection until very late stages, with only about 1 in 5 having received treatment. But even with that modest access to treatment, we are, for the very first time, beginning to see a decline in the HCV mortality, as we just reported yesterday in our surveillance report, a decline of 7% in HCV-related mortality. So we are beginning to take that step toward that elimination goal. We know certain interventions can improve the so-called care cascade from testing to cure, as I'll show you one example in a moment. But one major barrier has been the high cost of treatment when these drugs first came out in 2014. Now, since that time, the prices have fallen dramatically as a result of competition and other factors, to where we're very much in a cost-saving territory when treatment is applied as an intervention. However, these many payers continue the restrictions they put in place originally because of the budgetary impact of these higher cost treatments. That, plus the failure to test and to refer, is causing the number of people beginning treatment to fall precipitously. And so we need to maintain high testing and treatment coverage to reach our elimination target. One shining example of what can be done is the Cherokee Nation of eastern Oklahoma, where the leadership set an elimination goal for the population, recognizing the health disparity that is hepatitis C for American Indians. They adopted a universal testing policy. They put in provider education and other interventions to prompt testing, linkage to care. They got mid-level providers, such as pharmacists, involved in providing care, and they found out ways to finance all of this within their health system, testing and treatment. And as a result, they have tested over the 50% of the adult population in about 3 years. And they are doing an excellent job of referring them to care, and they're getting very successful outcomes of those people who are getting treated. So they are making excellent progress to the goal that they have set for themselves. The new concern we have as a country is the 300% increase in HCV incidence since 2010 through 2016, with over 80% of those cases related to injection drug use. The profile of the population experiencing this rising incidence is adults less than 40 years of age. They're most predominantly white, living in suburban and rural areas, particularly in states of Appalachia, the Midwest, and New England. And these increases parallel the increases in prescription opioid and heroin use. And we have an equal increase by male and female, as you can see there to the right. Now, one of the challenges for our interventions to prevent this incidence is access. We know from studies that if you bring together drug treatment and access to clean injection equipment through safe injection programs, you have about a 70% decrease in transmission. Models tell us that if you then add on HCV testing and treatment, you can get that prevention effectiveness up to about 90%. Regrettably, we have a very small number of syringe service programs that you can illustrated by the triangles on this map, and they're very much in geographic discordance from where the states are that have the highest incidence and where young people are living with hepatitis C, noted by the red dots. So we need to increase the number and increase the access to this intervention. In addition, many states deny treatment to people with a history of recent or current injection drug use, the very population that's at the highest risk of infection and transmission to others. So we really need to do a very good job of bringing all of these interventions together for maximum impact. A couple of populations that are a concern because of this epidemic. Number one, the increasing number of young women with hepatitis C means an increase in the number of pregnant women with hepatitis C, posing a 6 to 12% risk of transmission to their infant. And it's really a very sobering statistic for states such as Kentucky, the high rates of HCV among pregnant women as recorded on birth certificates. So this rising incidence of HCV generally and the rising incidence of populations such as pregnant women is really fueling stronger considerations for a routine testing recommendation for all adults, including pregnant women. The other population that needs to be targeted are the incarcerated. There's about a 15% prevalence of hepatitis C generally, with wide differences by geographic area and by testing type. Models tell us that if you can test and treat, obviously you're going to lower mortality risk for the incarcerated and probably protect the community also, because those people will be cured if they return to high-risk behaviors after release. Regrettably, most prison systems do not provide these interventions, and prisoners are resorting to lawsuits to try to gain access to these life-saving treatments. We also recognize that there's still work to do to improve the delivery of these interventions and maybe even develop new interventions. There's still a role for hepatitis C vaccine to prevent the high incidence that happens right after the initiation of injection drug use. Point-of-care tests could increase access to testing. There's new interest in developing better hepatitis B therapies, and we need field trials to really see how well this hepatitis C testing and linkage to care can work for people who inject drugs. And throughout this, we need good data systems to see how well we're doing and how well we're progressing toward our elimination goals. In summary, we have a growing interest in elimination. We now have goals for the elimination both for the world and for our country. And now, through this Public Health Grand Rounds, we can begin to look at some of the essential components of elimination programs. The importance of political support and community mobilization, planning, implementation of sound implementation strategies, a focus on key populations, and the use of strong evaluation data. And you're about to see several examples of that. And it's at this point, it's my pleasure to introduce Katie Burke to talk about the experiences in San Francisco. Thank you.
Good afternoon, and thank you to the CDC for the opportunity to speak today. My name is Katie Burke, and I'm the Viral Hepatitis Coordinator at the San Francisco Department of Public Health. I'm also an NHEP-CSF co-founder and coordinating committee member and a governance council member of Hep B-Free Bay Area. I'm going to share some elimination strategies for both hepatitis B and hepatitis C in San Francisco. So San Francisco is heavily burdened by hepatitis B. Approximately 1/3 of our general population in San Francisco are people of Asian or Pacific Island descent, and our hepatitis B cases are concentrated in this group. In fact, about 88% of our chronic hepatitis B cases are among Asian or Pacific Islanders in San Francisco, and there can be multiple barriers to recommended testing and treatment interventions in this group. The San Francisco Department of Public Health houses a perinatal hepatitis B vaccination program in which we track hepatitis B positive women and ensure that their infants are given the birth dose vaccine. As a result of this program, we've had no new perinatal infections in San Francisco since 2011, despite about 140 to 180 infants born to hepatitis B positive women born each year. This is a significant victory for our hepatitis B elimination efforts in San Francisco. I want to also acknowledge the work of San Francisco Hep B Free, which launched in 2007 as a public and private partnership with the mission of turning San Francisco into the first Hep B Free city in the nation. They were very much a group in which was ahead of the curve in terms of envisioning hepatitis B elimination. And they're well known for the Which One Deserves to Die campaign launched in 2010 that drew attention to the statistic at that time that 1 in 10 foreign-born Asian Americans were chronically infected with chronic hepatitis B. The CDC supported Hep B Free to perform 10,000 hepatitis B tests in community-based settings between 2012 and 2014. Hep B Free has also done extensive outreach to Asian-owned businesses and provided education and support. Their focus this year has been on expanding into San Mateo County to become Hep B Free Bay Area and launching a hepatitis B linkage phone line. The media campaign, in combination with the increased testing activities, is correlated with an increased positive hepatitis B case report at San Francisco Department of Public Health. And this is likely attributable to the increased testing rather than increased incidence of hepatitis B. San Francisco Department of Public Health has been a key partner of Hep B Free. We provide office space for the initiative and also an advisory role. San Francisco is heavily burdened by hepatitis C. We had about 1,000 new case reports in 2016, and among those case reports, 30% of them were African American, which points to a significant racial disparity in our hepatitis C burden among that group. Based on our best information, it's estimated that 22,000 San Franciscans are antibody positive for hepatitis C, and about 12,000 people are currently infected with hepatitis C. People who inject drugs make up 68% of our active hepatitis C infections, with men who have sex with men, baby boomers, and trans women also experiencing disproportionate burden of hepatitis C. Our estimate of 12,000 viremic hepatitis C individuals accounts for an estimated 4,000 to 5,000 hepatitis C cures in San Francisco as of early 2017. And this is based on reports from medical providers that were collected by NHEP-CSF. We're fortunate in San Francisco to have a strong drug user health infrastructure that supports our hepatitis C prevention, testing, and linkage efforts. The red stars on this map are syringe access sites in the city. They're concentrated in the downtown area, but we have an extensive network of secondary exchangers that increase our risk to less centralized neighborhoods in the city. Our syringe access sites provide access to naloxone, and in many cases, they're co-located with HIV and hepatitis C testing. Syringe access staff also provide referrals to drug treatment programs, including low-threshold buprenorphine and methadone, which is offered at a variety of clinics around the city. In response to the hepatitis C burden, as well as the opportunities afforded by the advent of curative hepatitis C treatment, NHEP-C officially launched in 2016, and we're currently in our third year of operation. NHEP-CSF utilizes a collective impact framework, which is a model in which multiple stakeholders come together to address complex social problems. In this case, the problem being how to eliminate hepatitis C in San Francisco. We're engaging epidemiologists, syringe access providers, drug treatment providers, AIDS service organizations, clinicians, advocates, and community members in the work of Hep C elimination so that our activities become mutually reinforcing. We have 33 public and private partner organizations signed on as part of the initiative, and we have a coordinating committee and 3 work groups that meet each month. The coordinating committee of NHEP-CSF is really the leadership group. They ensure alignment of our varying work group initiatives, and they make funding decisions for the initiative. We have 2 representatives from each work group on the coordinating committee, as well as key liaisons to methadone programs, drug user health advocacy groups, and the local hepatitis C task force. We try to really balance our clinical and epidemiological membership with community membership, and ensure that we have members with lived experience on the coordinating committee, as well as members that work with highly impacted communities, such as homeless people, people who inject drugs, and African Americans. We also believe that culture change is necessary in the way that we address hepatitis C in the community. We have to really shift away from a lot of antiquated ideas about hepatitis C, such that hepatitis C is unavoidable for people who inject drugs, that cures are unattainable, that anyone is in any way undeserving of hepatitis C treatment. And to shift these narratives, we really believe it's essential to involve peers to lead our community engagement efforts. So at NHEP-CSF, we prioritize involving members representation of impacted communities on our leadership groups, but we also like to create specific platforms for participant engagement that are lower threshold. You'll see here some photos from our Tales from the Cured community event back in last August of 2017. We also had a Get Cured, Stay Cured community meeting in March of this year. In both of these meetings, we featured panels of peers that had been cured of hepatitis C that spoke to other peers about the impact of being cured and how the impact of being cured on their lives, and encouraged folks to also seek treatment. We have a couple of different other community engagement projects underway this year, including the creation of a video that will feature patient testimonies, as well as we'll be funding some cohorts of peers and a couple of different community-based organizations who have been cured and can go on to educate their friends and members in their social networks to also get cured. All of our agencies involved in community-based testing meet monthly in the Prevention Testing and Linkage Work Group to explore our strategies and decide what's working well and should be expanding and what strategies need to be readjusted. The San Francisco Department of Public Health trains community-based organization staff so that they can be deployed to provide rapid Hep C tests in high prevalence settings, such as syringe access programs and shelters. The Department of Public Health also uses grant funding to support lab-based Hep C testing in high prevalence settings, such as the county jail and methadone programs. Our community-based testing numbers have significantly increased leading up to and over the course of NTEP-CSF's growth. We did close to 3,000 rapid community-based tests in 2017. Our Prevention Testing and Linkage Group reviewed these data regularly. The lower blue line is the number of antibody reactives. So we've ensured that there's a relatively steady antibody reactivity rate of around 18% as we've scaled up our testing numbers. We want to make sure that we're utilizing these resources to test highly impacted individuals in high prevalence settings. These data also help us to understand homelessness and its relationship to hepatitis C. Almost 3/4 of our folks who tested antibody positive in community settings report homelessness or housing instability in the prior 12 months. Also, over 90% of people who test positive, antibody positive, report having ever injected drugs. We have identified a small cohort of HIV negative non-injectors who report stimulant smoking as their only risk factor, and we're interested in an initiative as exploring this further. In terms of our treatment expansion work, the San Francisco Health Network is a network of 10 community-based and 2 hospital-based primary care clinics that are run by the Department of Public Health. These are all considered safety net clinics that treat high prevalence populations. And when new treatments became available in 2014, a bottleneck effect was created by having to refer patients to specialty care to be treated. To address this, the Health Network undertook a primary care-based treatment initiative to empower primary care clinicians to prescribe Hep C treatment on-site in their primary care clinics. This involved in-person trainings, e-referral support, and on-site clinical technical assistance. We did an analysis of the impact of this initiative and found significant increases in treatment. And in addition, dozens of providers began newly prescribing hepatitis C treatment in primary care. And we've treated more than 600 individuals in the San Francisco Health Network primary care clinics over the past 2 years. Our treatment access work group of NTEP-CSF has also worked to expand hepatitis C treatment beyond clinical care settings. We know that many people aren't engaged in primary care but are seeking care in other settings such as drug treatment or sexual health clinics or in the jail. We tend to treat in smaller numbers in these settings because these are often patients who require additional support such as peer navigation or groups or reminders in order to complete their treatment. But these are high impact interventions as many of the folks that we're treating in these settings are active injectors. And so we're really actualizing our treatment as prevention work. These are the most up-to-date data, and many of the folks being treated are now currently in the process of finishing up their treatment, which is why our treatment completion numbers don't match our treatment start numbers. But it is also worth noting that we've had several anecdotal reports of patients who have not quite finished their regimens and still end up with blood work indicating that they've been cured of hepatitis C, which speaks to the effectiveness of the medications. So NTEP-CSF has provided a good foundation, but additional resources are needed for to scale up our surveillance, testing, and treatment interventions. And we have a particular need for resources for interventions in vulnerable populations. We found that support services are really key for successful outcomes here. We believe these resources are essential as this is a winnable battle, and we have made significant progress already in San Francisco. So thanks to our community collaborators, and now it's my pleasure to introduce Dr. Kim Page.
Thank you very much. It's a pleasure to be here. Thanks to the CDC for having us and for inviting us to present. I'm going to tell you a little bit about what's going on in New Mexico and why we think New Mexico is really in a good place to proceed with and could be successful with Hep C elimination. So first of all, a little background. New Mexico has a disproportionately high burden of hepatitis C infection. Based on laboratory reports in 2016, the New Mexico Department of Public Health estimated that there were over 53,000 individuals with a positive test for Hep C. The proportion represented by this is over 5 times higher than seen in other areas of the U.S. with enhanced surveillance. Using methods described by Deniston and Edlin and using Hep C rates found in other groups, including the homeless, people who inject drugs, and others, my group did separate modeling of Hep C infection burden and came up with comparable numbers of about 53,000 people. So New Mexico also has a disproportionately high rate of liver disease morbidity and mortality compared to U.S. averages. Liver disease mortality in 2015 was 25 per 100,000 persons compared to a U.S. rate of 10 in 2014. And hepatocellular carcinoma is also high in our state. It disproportionately impacts Hispanics among men and American Indians among women compared to white non-Hispanic peoples. Following national trends, hepatitis C is increasing in young adults in New Mexico. Over the past 10 years, our Department of Health has focused surveillance for hepatitis C in people who are under age 30. Monitoring trends of hepatitis C in young adults is highly informative because these infections are likely recent and reflect incidence. The number of reported cases peaked in 2015, but remains high at almost 1,000 cases in 2017. The majority of these young adults with newly detected hepatitis C report injection drug use, at least 80%, as the likely transmission route. Our research, also in young adult people who inject drugs in a CDC-funded study, also shows high prevalence and incidence of Hep C in young people who inject drugs, 65% with exposure and 45% actively infected. This is higher by about 10% than what we've seen in our urban cohort and other locations in the same age group. The Hepatitis C Elimination Collaborative in New Mexico started in 2016. We all came together, multiple stakeholders, including from our Department of Health, the University of New Mexico, the Department of Corrections, Indian Health Service, the Albuquerque Area Southwest Tribal Epidemiology Center, and Tricor Laboratories, and together we all agreed to adopt an incremental approach to Hep C elimination with a focus on our Medicaid population. This may not sound very incremental because 50% of our population is covered by Medicaid in the state, but it's inclusive of multiple risk groups and represents about half of the population, and there's data. So we formed a collaborative that was structured with a steering committee, which included representation from 5 work groups illustrated in this slide. And each of these groups are tasked with reviewing current status as part of the strategic planning process and setting goals. All of these groups are committed to advocacy, policy, and practice change to advance Hep C elimination in our state. These are the factors that we think contribute to feasibility of Hep C elimination in New Mexico. 1, data. 2, high treatment access, a high-quality care model that makes treatment highly accessible, extensive prevention and treatment for people who inject drugs, and programs by our Department of Corrections. And I'm going to describe some of these to you in a little more detail. First, our Research and Strategic Information Group is tasked with gathering as much data as we can. A lot of what you've heard here today represents some of that, our 2016. It's pivotal to characterizing the epidemiology, extent, and burden of disease so as to inform goal-setting metrics to evaluate the quality and monitor progress towards elimination. We have quite a few research field trials that can help guide Hep C cure as prevention strategies for people who inject drugs. We have now compiled our estimates of disease prevalence, treatment, and prevention for the state for 2016. We also have a registry on our wish list. We actually have a precedent for the registry, our cancer registry, and we also have an HPV registry in the state of New Mexico. So you never know, we might get there. 2, hepatitis C treatment is highly accessible in New Mexico. As you know, Medicaid programs have faced major challenges in defining affordable treatment plans. A collaborative model was started in New Mexico that expanded treatment benefit over a 2-year period from individuals with advanced fibrosis to all individuals with chronic hep C, with the resultant 8-fold increase in members treated annually. The factors critical to this success were very strong leadership and collaboration from our Medicaid groups, managed care organizations, contractors, Project ECHO, and advocacy groups who committed to explicit evidence-based treatment guidelines and a realignment of financial incentives to promote treatment. Note that we actually have a goal of treating at least 1,500 people per year, and we only reached 1,200 last year. There's an economic consequence to that. Project ECHO, as Dr. Ward noted, the need for simplified care models that can expand Hep C screening. Project ECHO is one of the jewels of care delivery and knowledge dissemination in our state, and it's key because we have vast territory with dispersed rural populations, and we have a lot of poverty. Dr. Sanjeev Arora started ECHO as a way to meet local healthcare needs for Hep C in the interferon treatment era and help thousands of New Mexicans with Hep C get treatment they needed by making specialized knowledge accessible where it was needed in their own communities. For some people, it can be a 3-hour drive to an academic medical center. So ECHO changed the rules. Treatment for Hep C is now available at centers for excellence across the state. Currently, over 3,000 doctors, nurses, and community health workers provide treatment and support to more than 6,000 patients enrolled in ECHO's comprehensive disease management programs for several conditions. Fourth, to reduce Hep C incidence, there's a need to focus on people who inject drugs. We've estimated that there are actually over 20,000 active people who inject drugs in New Mexico using capture-recapture methods from prevention data collected by our health department. Prevalence of Hep C in the entire population is conservatively estimated at 60% in this population. Our Hep C elimination planning group and many other providers, both clinical and community-based, are committed to implementing effective and evidence-based policies to reduce Hep C in people who inject drugs. As a result, the New Mexico Department of Public Health supports an extensive harm reduction program, which includes syringe service programs, education, referral, and naloxone distribution. In 2017, over 6 million syringes were distributed, but this will increase, we expect this year, to 9 million because of policy changes at the state level. Medically assisted treatment for opioid use disorder is also widely available, and the number of providers for outpatient buprenorphine treatment is expanding, again with help from Project ECHO's Integrated Addictions and Psychiatry program led by Dr. Mariam Kamamari. There are still wait lists for MAT, however, especially slots for publicly funded programs, and also other drugs are prevalent in New Mexico, including stimulants like methamphetamine, and for which effective treatment programs are still needed. This just illustrates the breadth and depth of coverage in New Mexico. And if you look at the little yellow sites, these are our 3 urban areas. The rest of these sites, the little blue service points, are all in rural areas of New Mexico. And only the one big dot in the middle metro area, Albuquerque, Santa Fe and Las Cruces have populations of 80,000 or less. So our population is very dispersed. For people who inject drugs, hepatitis C is an important strategy to break the cycle of transmission. In our study of young injectors up in Rio Arriba County, and this is a rural area, 90% of them have medical insurance, making hepatitis C treatment very accessible to them. However, we're finding that compared to older people who inject drugs, they're not accessing treatment. So we really need new methods to educate and deliver treatment to this group. We are studying ways to improve and maximize treatment in people who inject drugs. We're one of 8 sites for the HERO study, which is assessing outcomes of Hep C treatment in active injectors at community and MAT sites randomly assigned to directly observed therapy or patient navigation. And so we're happy to be on that research arena. I can't really not at least mention the need for a Hep C vaccine. And in New Mexico, we are one of 3 sites which has enrolled active people who inject drugs into that study. Really, both of these studies have helped to inform ways to optimize treatment delivery for people who inject drugs and educate providers that they can be treated immediately. Finally, as others have noted, hepatitis C in our incarcerated populations is crucial to elimination. We have the highest recorded prevalence of Hep C in our prisons at 41%, but our Department of Corrections is active also with Project ECHO to deliver treatment, and we have a really impressive Hep C prevention program in prisons developed by Dr. Carla Thornton and Miranda Cedillo from Project ECHO that trains peer educators within prison facilities to provide hepatitis C, HIV, and STI prevention to inmates. To date, this program has reached over 5,000 prisoners. So to circle back to our strategy, the New Mexico Hep C Collaborative is now involved in strategic planning. It's ongoing now. We have a leadership committee that includes myself and Dominic Zerlo from the Health Department and Ann White from the Albuquerque Area Southwest Tribal Epidemiology Center. And we're setting goals that include both short and long-term ones. As with San Francisco, we have some resource needs which we believe would help us move forward quicker. Each group now has access to our 2016 estimates and is in the process of defining goals, strategies, indicators of progress and success and metrics for both a 5-year and a 2030 goal. Note that the bottom illustration is an example of the types of goals that are being defined, so this is a work in progress. And with that, I'll end, and I am happy to introduce Dr. Ben Cowie.
Thank you very much, Kim, and I'd like to express my gratitude and honour to be here at the CDC presenting in these public health grand rounds and hearing some of the amazing work that's going on in the United States. So I've been asked to talk a little bit about Australian perspective on hepatitis elimination. So similar to the situation here in the United States, it's evident that liver cancer is the fastest increasing cause of cancer death of Australians and is now the 6th most common cause. In 2016, it was estimated that around 2% of Australians were living with chronic viral hepatitis, roughly equal proportions for hepatitis B and hepatitis C. And from the Global Burden of Disease study, you can tell there that we really do have a disproportionate burden of viral hepatitis mortality when considered relative to HIV in Australia. And again, similar to the situation in the United States, there really hasn't been historically the same investment in viral hepatitis as has been the case for HIV. We know that liver cancer as well is still characterised by a very low survival with only 16% 5-year survival, and so we really urgently need to prevent these cancers rather than trying to treat them once they occur. So how can we reverse this situation, and what's an example of how we might address the burden of viral hepatitis? So specifically addressing hepatitis C with these new cures that the other speakers have been talking about, Australia did approach the issue of financing of DAAs, or directly acting antivirals, with quite a comprehensive negotiation process with the pharmaceutical companies. But the end result of which is that the cost per cure in Australia is actually one of the lowest in the OECD, at around $7,000 per course of treatment for hepatitis C, and that's the total price paid by the government. The price to patients, the co-payment under our national insurance scheme, is approximately $30 per month for people who don't qualify for concession. So this is around 10 times cheaper than some other comparable countries in the OECD. And this has really unlocked the opportunity of driving forward hepatitis C elimination in our country. I'd like to acknowledge this is a slide from Andrew Hill from the University of Liverpool, who presented this at the World Hepatitis Summit. There really is a very gross disparity in the prices paid for these drugs, and not just when looking at generic drugs used in low and middle income countries, but across a range of high income countries with similar health systems. There's real disparity in the prices of these drugs, which we need to address. So this financing arrangement, how has it actually stimulated our approach to elimination of hepatitis C in Australia? It meant that there's a strong financial incentive for the government to make access as liberal as possible. So any doctor in the country can now prescribe these drugs. It's not restricted to specialists. And in fact, most scripts for these drugs are now written by family doctors or general practitioners in Australia. There's no restriction on stage of liver disease. Treatment in prisons is specifically incorporated under this national funding, as is treatment of active injectors and retreatment as many times as is required if someone does get re-exposed and reinfected. It's also meant the government has a vested interest in trying to educate the workforce and fund community education programs to try and avail this opportunity of the cheapest possible treatments during the period of this agreement. But there are some gaps, which I'll come back to, particularly in regional areas of Australia and also amongst Aboriginal and Torres Strait Islander peoples. In contrast, the situation for hepatitis B remains a lot more static, with treatment uptake and access to diagnosis remaining fairly stagnant. And it still is characterised by a specialist or hospital-centred model of care. So it's easy for us to see these cascades diverging and what some of the underlying reasons for that are. It is also clearly the case, as has been picked up by previous speakers, that we need to continue our focus on prevention to keep downward pressure on transmission and new infections as we increase access to treatment as we move towards elimination of hepatitis C. The history of harm reduction in Australia is a fairly good one. There's government-funded needle and syringe programs throughout the country, and opiate replacement therapy is also funded by a national insurance scheme as well. We have medically supervised and safe injecting room in Sydney for some years now, and there's one about to open down in Melbourne, where I live. There's also government funding for peer support and community organisations for people who inject drugs. We still don't have any needle and syringe programs in prisons, however. But there really is this focus that we need to turn off the tap. We need to give people the opportunity to avoid being exposed to hepatitis C whilst we're treating those who are already infected. For hepatitis B, obviously has been picked up by John in his presentation, free hepatitis B vaccination, which is highly effective, has been available for infants and for a range of high-risk priority populations for some years. So this is the cascade of care for chronic hepatitis B, where we estimate that around 2/3 of Australians living with hepatitis B have been diagnosed, but that concerningly around 85% of Australians with hepatitis B are not receiving guideline-based care. And this translates down to around 7% being on antiviral treatment, which is less than half the proportion we estimate or we target in our national strategy. And as you can see at the bottom panel there, really this is not shifting year in, year out. This is a fairly stagnant situation. And so we need to unlock the sort of transformation or disruption for hepatitis B that we've seen with hepatitis C. So prior to the listing of the direct-acting antivirals on our pharmaceutical benefits scheme on the 1st of March of 2016, we did have a relatively high proportion of people living with hepatitis C who had been diagnosed, but only around half of those had gone on to have confirmatory PCR testing to detect replicative infection. But 1 to 2% of people were receiving treatment, which is less than the number of new infections that were occurring each year. So these are slides from my colleague Greg Dorr from the Kirby Institute showing what happened after 2016 when these drugs were listed on our pharmaceutical benefit scheme. So in the first 10 months of the treatment program, we estimate that 14% of all Australians living with hepatitis C received treatment by the end of that calendar year. So these are some reports we've recently published. It's important to look at national trends, but it's also really important to look down to local geographic levels. So you can see areas that are doing particularly well and then translate some of those learnings into areas where the uptake of treatment and care is not as encouraging. And I'm going to pick out the hepatitis C mapping report for a little bit of closer examination. So this is the data now for the first year of the treatment program, up to the end of February 2017. You can see the national average there at about 18% of people living with hepatitis C had been treated. But in the highest treatment areas, it was more than a quarter. And in the lowest treatment primary health networks in our country, it was less than 10%. So some very stark evidence of disparity in access to treatment and care, which allows then for those state governments and for the national government and professional groups to go in and target these areas for community awareness, but also health workforce development. So a couple of points about some of the key priority populations that have been coming through in the previous discussions, particularly living with hepatitis C. So acknowledging Jenny Iverson, a colleague from the Kirby Institute who presented these data at the INSU conference here in the United States in New York last year. So in the first 6 months of the treatment program, there was evidence that people who were actively injecting drugs and engaged with needle and syringe programs had a higher treatment uptake than was the case in the general population. And that in fact, for people participating in those needle and syringe programs, the viremic prevalence with hepatitis C actually dropped by 25% in the space of 1 year. So for people actively injecting drugs using needle and syringe programs, a 25% drop in the viremic prevalence of hepatitis C. This is the kind of things we need to see if we're going to achieve elimination. The other thing we're going to need to see, picking up Kim's point, is prison-based treatment. My colleague Darren Russell from up in the top end of Australia, up in North Queensland, their treatment program in prisons has seen the effective elimination of hepatitis C from several of their prisons up in Queensland. And there are examples of this in other parts of Australia where effectively people are screened on entry and all people are offered treatment for hepatitis C, and the existing population of people infected with hep C in the prison have already been treated and cured. So this is really encouraging of how we can access some of the hard-to-reach populations. So is Australia on target to reach the 2030 elimination target set by the WHO? So for hepatitis C, some modelling presented again by Greg Dorr at our Australasian Viral Hepatitis Elimination Conference, which we held last year. Yes, we're on track to eliminate hepatitis C. There's a typo on that slide, it's not 2060. So in the intermediate treatment scenario, which is what we're heading for at the moment, we're probably going to achieve elimination by 2026 to 2028, based on those WHO goals. For hepatitis B, no, we're not going to achieve that, and so we need to intensify what we're doing. We need to scale up diagnosis, treatment and care significantly. And it's also important to remember that, as is the case in the United States, most people living with hepatitis B in Australia were born overseas in our own region, the Asia-Pacific region, and we'll see the real impact of those vaccination programs in some of those priority countries start to come into play in the next few decades, as the prevalence in our migrants will drop very substantially. And we're already starting to see that from some of those countries now. So what can the difference in these trajectories teach us about what is needed for countries like ours to achieve the elimination goals? So we do need to keep a continued focus on prevention, including harm reduction. We need to reduce the costs of care, and that's not just about pharmaceutical costs. It's also about diagnostics and monitoring and access to the consultations themselves. And universal health coverage is the way to do this. We need community-based and, importantly, a primary care focus of treatment. That's really essential. We're not going to treat our way out of this if we rely on hospitals and specialists, and it'll be a lot more expensive as we try. We need to engage those most effective. That's been crucial to the HIV response, and people living with viral hepatitis need not only to be partnered with, but to be leading these responses as our approach to elimination matures. We need innovative methods to assess coverage and look at areas where the response is lagging and implement widely that which is working. And we need global solutions, because no country will achieve this elimination in isolation. And so really, forging global partnerships is how we're going to achieve elimination of viral hepatitis. Thank you very much.
Thank you all very much. I think we have some time for some questions. I think, Paula, do you have some questions from the external audience, please?
Thank you. So from our mailbox at grandrounds@cdc.gov, from Elaine, she writes, I am almost 71 years old. In 1965, I had a blood transfusion, or several actually. Should I be tested for hepatitis C after all this time?
Yes, you should be. Blood transfusions were not screened prior to 1992. The risk was very high from blood exposures, and it's a silent infection, and you may have hepatitis C and not be aware of it. So yes, it's very important for you to be screened immediately. I think we'll take a question inside the room. I think we want to start off With Dr. Doug Lowy is here. He's the Deputy Director of the National Cancer Institute. He's visiting today because of his interest in this public health grand rounds. Doug called me up about a year ago and said he had read the National Academy's report and said, you know what, I think we can eliminate hepatitis C. And I said, I think you're right. So we've been having some nice discussions since that time. And so I wanted to welcome Doug to CDC and see what his comments and questions were at this point.
Thank you very much, John. This has been really informative. My question is, how do we change the prison situation from being a challenge and a problem to being an opportunity for great success?
It's a difficult question. I'm sure some others on the panel will have comments where the federal system is moving along quite well. They have standards of care, and they're really making some inroads into treatment. But you have multiple systems at the local and state level, and you have to approach them individually, and they have varying political commitments and budgetary issues and awareness. And so it's going to really take changing the political priorities locally, maybe developing some good models of care that can be readily applied, continuing to look at the affordability of treatments and doing some cost-effectiveness modeling that can make the case within those systems, and then developing some local champions that can manage those programs. But I'll turn it over to my panel here and see what other comments they may have.
Thank you. Look, it's such an important question. So in Australia, traditionally, the federal government, the Commonwealth, has not been responsible for treatment costs in prisons. That's all the responsibility of the jurisdiction, states and territories. However, it was clearly the case that we understood that there was no way we were going to achieve any of these sort of elimination targets if we had a piecemeal approach to that. So the government actually specifically, under the Pharmaceutical Benefits Scheme, listed these drugs in two different ways to enable the prisons to actually access them, funded by the federal government, but then administered through the state health systems serving prisoners. So actually realising this as a priority and having partnerships between the levels of government allowed that to be an option. And then picking up your point about local champions, then some of the prison services just basically took this on and said, we're going to get rid of Hep C in this prison and we're doing it now. And so once some prisons saw this happen, they were going, wow, we can do this. We can get rid of this condition in our prison. And then it's just really sort of charging along from there.
Kim, Katie?
We want that. If we had that combined with the kind of prevention program that we have going on in our prisons in New Mexico, it would make a big dent. And that's what we have to do to get to the, to have the kind of public health impact that we want. We must remember that people who are in prison, most of them don't stay in for very long periods, but they go back out into their communities. And so, it helps everyone, not just prisoners.
We also, in San Francisco, were fortunate to be funded by Gilead to do a study where we treated 100 people that were in the county jail and then released to the community mid-treatment so that community navigators would then work with those folks to get them connected to community clinics. And we found, of course, that it's feasible. You can do this. You can start people in treatment in jail and complete treatment in the community. And really what we're discussing now is if there are any pharmaceutical companies that will use patient assistance programs to give us the drugs so that we can start treatment for folks in jails, sort of beyond the end of the study. Like that's the kind of X factor for us. And we're making a little bit of progress on that conversation.
Anne?
Yeah, hi, Ann Chookett, Deputy Director. Thanks for a wonderful set of presentations and for all the work that you all are doing. The nation is in the midst of an opioid epidemic, which is getting unprecedented levels of attention and focus. And so I'm curious at the state of New Mexico and at the city of San Francisco level, where you're involved in consortiums and coalitions and really attacking the problems with the high overlap with injecting drug use and hepatitis C, whether you have any comments about, having sort of that addiction or opioid driving versus, the hepatitis prevention with the available treatments, whether there's sort of a best way to make progress from your perspectives.
For NTEP-CSF, I mean, I think that we really were fortunate to rely on existing models that we had in place already for overdose prevention and engagement with drug users and letting sort of drug users lead in those interventions and efforts. And I just want to acknowledge the work of the DOPE Project, of the Harm Reduction Coalition, that's been doing peer-based naloxone distribution in San Francisco for going on 18 years now. And we've found over and over every single year, the more naloxone you get out into the community, into the hands of drug users, the higher sort of reversal rates we have, and our overdose death rate has plummeted. And so we've been a little bit protected in San Francisco. We haven't seen the same level of increase in overdose deaths and Hep C cases, acute Hep C cases. We've had a little bit of a bump in both due to the influx of fentanyl in our drug supply and due to, by all indications, all markers, kind of increased substance use, but we haven't sort of seen those outcomes. And so I think for NTEP-CSF, it's been really important for us to sort of learn from the models that have been really successful in addressing opioid substance use, and also to work on making low threshold buprenorphine and methadone to kind of continually figure out ways to increase access to that in our city.
Kim, quickly.
That little tiny decline that you saw in our Hep C cases in young injectors is mirrored by a little tiny decline in our overdose rate. New Mexico has now gone from 2nd to 5th in our overdose rate, which is actually a good thing. But we've had significant policy changes at the state level, which now makes naloxone distribution available to many first responders, and anyone can go into a pharmacy. We have big social marketing programs. We have some really interesting academic and law enforcement partnerships going on also to try to work with the problem, and but it is something that's consuming our state and is very important.
I'd like to take a moment to thank the speakers for an excellent presentation. Thank you. And I'd like to thank our audience for joining us. We'll see you next month for Public Health Grand Rounds.
Thank you.